Hi, good afternoon, everyone. We're here with the App Foundation in another community forum. These forums are set up to bring clinicians in to speak with policymakers and administrators and members of the general public and people with lived experience on different topics to spark and enrich our understanding and to bring the good work that the App Foundation is doing out into the community in another way. So today, with May being Hepatitis Awareness Month, we are going to focus in on that overlap where substance use disorder becomes a risk factor for hepatitis and how the screening, evaluation, and treatment environment can co-overlap and support each other. And to speak to that, we have Ben, who is well experienced in working with the APT Foundation on a, Ben, why don't you explain your role and your relationship to Dr. Shi, and we'll get started.
Sure. Well, thank you for giving me the opportunity to share about hepatitis C and all the work that APT is doing both internally and in the community to address this issue. I'm APRN. I'm new to the APT team, but I work in the Central Medical Unit at Long Wharf, along with Dr. Shi, who's our medical director, and along with a larger team of nurse practitioners and physicians that provide primary care and addiction medicine to our patients. But in addition to that, we're also experienced in providing hepatitis C, both screening and treatment in our office as well. So that's what I hope to share a little bit about with everyone today.
Well, thank you very much. And Dr. Shi, of course, has been at the forefront of the APT Foundation research program and mentoring for quite some time. Is there anything you would like to go over for background on this topic?
Sure. Hi, I'm Julia Shi. I've been the medical director at the Central Medical Unit for almost over 30 years. And I remember when I first started, hepatitis C doesn't even have a name. It was called non-A, non-B hepatitis. And at the beginning of my fellowship here, we actually took on evaluating the seroprevalence of how frequent, individual using drugs has been had been positive for the non-A, non-B hepatitis, eventually, called hepatitis C. And so the research on, hepatitis treatment at APT Foundation had been ongoing for more than 30 years. And with the new therapeutic, it has just really, I would say, revolutionized this treatment. And I'm so excited that Ben is able to take this project on, and this would be his doctorate degree. So in the next year or two, he would be able to be a doctor of a nurse practitioner. And this really helped, us kind of consolidate a really easy program, hopefully that can be adopted in the rest of the community to try to encourage treatment of hepatitis C. And hopefully with this community forum, we can allow, clinicians from and also social worker from, so the rest of the community be able to refer patients so that we can get them all treated and so that they can be on their way into better health. So I'm gonna give Ben the opportunity to start his talk, and which had been fantastic. So go ahead, Ben, all yours.
Well, thank you. Okay, so we'll go ahead and get started. So we'll be talking about hepatitis C today. As was mentioned earlier, May is Hepatitis Awareness Month. So the various kinds of hepatitis, hepatitis is a general term for inflammation of the liver. There are many causes, but in this case, we're focusing in particular on the hepatitis C virus as it impacts our specific patient population. So what is hepatitis C? So hepatitis C is a single-stranded RNA virus. So different kinds of viruses have different genetic structures. So some are DNA viruses. In the case of Hep C, it is an RNA virus. It belongs to a family that includes other viruses such as yellow fever. There are 6 main genotypes that we're commonly familiar with in treating Hep C, but there are 8 in all. There were 2, genotype 7 and 8 were recently discovered, but they're in a very tiny patient population. So 1 through 6 are generally what we're concerned with. There are 86 different subtypes, however, so they all vary slightly in terms of their genetic makeup, but they all fall under the categories of 1 through 6. Genotypes 1A and 1B are the most common in North America. We see those most commonly in patients that are coming in for treatment, but 2 and 3 are also very common. And genotype 1 overall accounts for about half of all Hep C infections worldwide. So just an overview, Dr. Shi alluded to this already, but the discovery of Hep C was relatively recent. So Hep B was discovered first in the 60s, followed by hepatitis A in the 70s. And we knew there was another virus that wasn't accounted for, but we had a hard time identifying it. So it was formally isolated in 1989. Before that, it was known as non-A, non-B hepatitis. And the first therapeutics came about in the 1990s. So many people are aware of interferon, which was the mainstay of treatment in addition to ribavirin. And then in 2011, we had the introduction of newer medications called direct-acting antivirals, or DAAs. And this is just an overview of how hepatitis C is distributed throughout the country. So we estimate, based on reports, that there are about 2.5 million people in the United States that are living with hepatitis C. That said, the actual number could be quite a bit higher, closer to 4.7 million. The reason for that is hepatitis C often flies under the radar, in part because people aren't getting tested with the regularity that they should be, and because people often don't have any symptoms. So there's no impetus for the patient to seek treatment. If they feel fine, they don't know that they're sick. So the estimates are probably much higher, closer to 4.7 rather than the 2.5 that we know about. Hepatitis C rates have been on the increase. Between 2010 and 2018, they've steadily increased, but in recent years, they've started to level off a bit and start to decline. But the rates did increase dramatically around the time that the opioid crisis was really kicking off. In 2019 alone, there were 4,136 cases confirmed, and about a third of those were attributed to IV drug use alone. The actual number, as we kind of alluded to before, is probably closer to 57,000 due to underreporting. The highest rate of patients that are experiencing new infections are younger patients in the 20 to 39-year-old category as of 2019. And by racial and ethnic category, Native Americans and Alaskan Natives have been the hardest hit. There are significantly higher rates of new Hep C infections among their ethnicity compared to the next highest racial or ethnic group. And this is just a graphic that kind of demonstrates the overlap of the hepatitis C epidemic and the opioid epidemic. On the left, the graphic represents states with the highest numbers of opioid overdose deaths since 2018. You can see it's mostly concentrated in the Northeast and in the Ohio River valleys. And that seems to follow with the rates of new Hep C diagnoses. So the darker colors on the right represent higher levels of infection, the darker they are. And just as an aside, the data that was used to create both of these graphics is from the same year, 2018. The graphic on the left was published in 2020, but it was using 2018 data. So it's all from the same year. So this is just an overview of the impact that hepatitis C has on individuals as well as our healthcare infrastructure. So the majority of people that get infected with hepatitis C, 75 to 80%, will develop chronic infection. The remainder, and some people will manage to clear the virus on their own, but the vast majority of people will develop a chronic infection with the virus. Less than 25% of patients that are infected have any clinical apparent signs or symptoms of the disease, which we mentioned before. So it goes undetected in people often for a number of years before they're diagnosed. So with regard to cirrhosis, that's something that people are often familiar with Hep C. There's a 2 to 5% risk of developing cirrhosis and decompensated or liver failure that goes up by 2 to 5% every year. So the longer one has Hep C that's untreated, the higher the risk every year for developing cirrhosis and decompensated cirrhosis. And 15 to 20% of people with advanced liver disease will die in the first year following decompensation. So once that happens, a good number of people will pass from that disease. And advanced liver disease in the United States causes about 20,000 deaths a year. One of the things that we worry about with hepatitis C, and especially in people with advanced fibrosis or cirrhosis, is something called hepatocellular carcinoma or liver cancer. The 5-year risk scores range from about 1% in people with liver fibrosis to 13% in people with liver cirrhosis. So it does increase year over year. And 66 to 75% of individuals with Hep C will experience what we call extrahepatic manifestations of Hep C. So those are things that happen outside of the liver, so the things that we're familiar with. So it can contribute to people developing heart problems with coronary artery disease, kidney failure, certain kinds of blood issues, so lymphoma or blood cancer in particular, blood clots. And it can also cause skin conditions and also contribute to the development of type 2 diabetes. So I often tell patients Hep C is not just a liver disease, it's a whole body disease. So that's an important thing for patients to realize, is that it's not just the liver, it can contribute to all sorts of health problems. And with all of this in mind, the economic burden of Hep C related liver disease alone, so not factoring in all the other extrahepatic manifestations like diabetes and heart problems. So just the liver disease alone costs the healthcare industry between $6 and $10 billion a year. So how do we get Hep C in the first place? So we get Hep C through something called percutaneous inoculation, which just means it's something crosses the skin barrier and interacts with the blood, and then we pick up the virus that way. So injection drug use is the most common way that people are infected with hepatitis C. Sharing needles and injection equipment primarily. The virus can actually live outside the body in dried blood for up to 6 weeks. It can still be detectable, but it lives much longer inside needles and inside syringes. So even if it's been a while since someone's used it, using an old syringe can still harbor the virus. Another way that people sometimes pick up hepatitis C, even if they've never injected, is by sharing straws used for intranasal drug use. So in people that snort cocaine or opiates, passing straws between individuals that have trauma to the insides of their noses can actually transmit the virus as well, even with just a very small amount of blood. Other ways that people can pick up hepatitis C is if they had received any blood transfusions or organ transplants before 1992, when we were able to better screen for hepatitis C. Sometimes healthcare workers can get it through accidental needle sticks. Children born to mothers with hepatitis C can also pick it up, although it's not terribly common. Only about 6% of babies born to mothers with Hep C will contract the virus. And it is not transmitted through breast milk. So it is, the CDC does say that it's safe for mothers to breastfeed their babies, even if they have Hep C. The virus is not well concentrated in breast milk. Another way that people sometimes get is through sexual contact with a hepatitis C infected partner. It is not very common for people to contract the virus this way, but in people that have, it's bound to be more common in people that have more than one sexual partner, people that have other sexually transmitted diseases that might cause a breakdown of the tissues in the sexual organs. And it's more common in men who have sex with men. And lastly, dialysis patients are at higher risk for contracting hepatitis C through infected dialysis equipment. And it can also be transmitted to people through tattooing or piercings that are obtained in unlicensed setting. Because again, it's a needle that's impacting that skin barrier that could transmit that virus. So what happens after we get exposed to hepatitis C?
A couple questions have come in. One was just kind of reviewing what the liver does in the body anyway. And so maybe we could start there. Like,
oh, great question. So the liver does a lot of things. So it detoxifies the blood. It processes medication, foods we eat. It stores blood sugar. It also manufactures cholesterol. So there's a whole lot of things that our liver does for us. And when the liver is not working very well, it manages to do quite a bit with even just very limited function, but we really depend on that liver. It's a very important organ that does quite a bit for us.
and it makes sense that some of the things that the liver does, then it has to work harder and under more strain when a substance use disorder is present, if it's clearing the blood. Is that a myth or stereotype, or that is true?
No, that's true. So there are a lot of toxins in substances that people use because they're not pure substances either. They have a lot of adulterants in them. So things that are used to cut the drugs to make the quantities a little bigger, or there are things that are added to the drugs that our body has to work really hard to manage. And oftentimes those hit the liver and we end up with liver inflammation from dealing with all that. So we kind of get a double whammy when we have something that's stressing our organ systems already with a virus, and then when people are struggling with substance use on top of it.
Right. Got it. Well,
that liver.
Well, back to this fun soon. I have a couple more questions, but I'll turn it back.
Oh, sure.
Okay.
So what happens after we get hepatitis C, or we're exposed to hepatitis C? So we can actually detect the virus in the blood within 1 to 4 weeks after we've been exposed. But that level of virus that's circulating in our blood reaches its highest point within 8 to 12 weeks after that occurs. And when that happens, the levels of virus will either plateau or level off, or they'll steadily drop until it disappears. And that happens in people who are able to clear the virus on their own. But as we mentioned, the majority of people will kind of plateau with the level of virus that's in their body, and they need help to treat that infection. And as we mentioned before, patients usually have no symptoms during the early stages of hepatitis C. If they do, it's most often during that acute phase. And sometimes people will have very mild hepatitis symptoms that we might be familiar with. So abdominal pain, upset stomach, yellow skin or eyes, but that is not very common at all. The vast majority of patients will have no symptoms and not even know that they were infected. An important thing is to know is that hepatitis C, when the virus actually enters the cells of the liver, is it doesn't actually kill the liver cells directly to cause the scarring. What causes the scarring on the liver is actually the inflammation that's caused by the virus being in there and doing what it's doing. The inflammation is also what leads to the other health conditions that are associated with hepatitis C. So diabetes, coronary artery disease, kidney damage, those sorts of things. So things that can make hepatitis C worse is using alcohol if people are drinking and using substances and after they become infected with hepatitis C. If they have an infection with hepatitis B, or HIV, genotype 3 of hepatitis C infection if they have insulin resistance, if they are have obesity, or they have something called non-alcoholic fatty liver disease. All of those things will accelerate the scarring of the liver. So it's important that we address all those factors when we are treating somebody for hepatitis C, because it can make that scarring on the liver go much quicker. And lastly, liver cancer risks increase with the degree of fibrosis. So we typically, in our practice, we use something called the FibroSure test. So it's a blood test that tells us the level of scarring that's on the liver, or an estimate. And it goes from 0 to 4, 0 meaning that there's no scarring at all on the liver, and 4 being cirrhosis. So the surface of the liver is totally scarred. So depending on what your score is, the higher your score, the more likely you are to develop liver cancer later on, in particular F3 and F4. So for those patients, we have extra monitoring that we do to make sure that we're catching that early if that does occur. So hepatitis C screening and treatment. So this is an example of a care cascade. So that term came from HIV care, but it kind of follows a lot of the same steps. So the first step in this chain of treatment is diagnosis. So screening is the first part. We know that somebody has hepatitis C. Now what do? We want to link them to care. So get them in to see a provider that can help them get started on treatment. The next chain is engagement or retention in care. So making sure that once we start treatment, that we help that patient stay engaged in their treatment, taking their medications, coming to their appointments, getting their blood tests done that are all part of the treatment process, making sure that they don't miss those important steps. Antiviral treatment is part of that process. And then finally, we end with viral suppression. So with medication, we're able to realize cure rates of about 90 to 97% with the new medications that we have on the market. So that's our end goal, is to help someone achieve cure of hepatitis C. So this is just a review of the treatment for hepatitis C. So I do mention interferon because some patients have mentioned to me that they have been treated with this recently, or that was offered to them as an option. But what is interferon? So interferon are proteins that inhibit viral protein synthesis. So that means that they block the ability of the virus to make more virus. They also inactivate the genetic material of the virus, the RNA, and they also help the body kind of gobble up the virus. So phagocytosis is the immune system kind of picking up all that virus and getting rid of it. Cure rates with interferon are about 40 to 60%, and they have a lot of side effects. So patients often don't feel well when they're receiving interferon. They have flu-like symptoms. They might have a low blood cell count, low platelets, and some people have neurocognitive effects. So it kind of affects their cognition or thinking. Interferon's usually combined with a medication called ribavirin, which is a pill, whereas interferon is injections or infusions. And ribavirin also kind of helps keep the virus from making copies of itself. So with the direct acting antivirals, the new drugs that have come on the market in recent years, the cure rate is, as I mentioned, is 90 to 97%, and it has very few side effects. So generally, if people do have side effects at all, they're very mild. People do complain sometimes of a mild headache. They may have an upset stomach or diarrhea. They may have trouble sleeping. And some people have mentioned that they might have like weakness or fatigue. Those are all pretty common. And even in people that do have more aggressive side effects, we do have a lot of things that we can do to help them manage those side effects through the course of treatment, which depending on the medication, which we'll talk about in a minute, is anywhere from 8 to 12 weeks of therapy, depending on the medications that we use. And the way that they work is they they interrupt the ability of the hepatitis C virus to copy itself. So they work similarly in that regard to interferon and ribavirin, but they work in more targeted ways to really interrupt the way that the virus copies itself. So these are the medications that are currently available in the new class. So Harvoni and Zapatir are available but are not commonly used, or the older medications. Epclusa is one of the medications that we use commonly in the central medical unit, but we also do use Vosevi and Mavorite. So they are combinations of different classes of antivirals. So Epclusa is a combination of 2 medications in 1 pill. Vosevi is a combination of 3 medications in 1 pill, and Mavorite is a combination of 2 in 1. The big differences between the two, or the 3 medications, are duration. So Mavorite patients are able to complete treatment in 8 weeks. It's 3 pills a day, every day for 8 weeks. And then Vosevi and Epclusa are 1 pill a day every day for 12 weeks. So we generally like to start with Epclusa. You can also start with other medications. It kind of depends on your unique medical history, your history with hepatitis C, what other medications you might be taking. So it's part of the initial encounter with one of our providers is kind of figuring out what medication makes sense for you. And I should mention also too, those last 3 medications are all covered on Husky formulary. So for patients with Medicaid, they are available to patients at no cost. So why are we focusing on hepatitis C? So a surprising statistic is about half of people don't know they're infected. And that's one of the biggest things that we are focusing on with screening, is making sure that people know their status so that if they choose to, they can seek treatment. And despite a rapid rise in new cases, which we mentioned between 2010 and 2018, the number of people that are starting treatment is actually dropping. So even though more people are being diagnosed, a lot of people aren't being engaged in care. Another reason is that people with substance use disorders are disproportionately affected by hepatitis C, and in particular, people who inject drugs. As we mentioned before, that's the way that most people nowadays become infected with Hep C. And it's also estimated that in people who inject drugs living with Hep C, they'll pass the virus on to as many as 20 other people in just the first 3 years of the initial infection alone. And often that's because they don't even know that they have the virus in the first place. Another reason is that more than 60% of opioid treatment programs in the United States don't offer even screening services for hepatitis C. And on-site treatment is even more uncommon. So really focusing on the services that we provide to the community is really important. So what are we doing at APT to try to address this issue? So we have an organizational goal of 100% opt-out screening for hepatitis C for all new patients. And what that means is that all of our methadone patients or patients that are coming into the methadone program are offered the opportunity to have screening. It's a standard part of the blood work, and if they would rather not be screened, they just have to let us know that they don't want to get that screening done. It is offered to them at the time that they come in to join the program. Another goal we have is 100% follow-up testing for all patients with positive hepatitis C antibody tests. So a common misconception that people have is that if their antibody test is positive, they definitely have Hep C. And sometimes that's not the case. So as we mentioned, between 1 in 4 and 1 in 5 people that contract hepatitis C are able to clear it on their own. In people that have had hepatitis C at any point in their life, their antibody will always be positive. So a more important test to get once we see that their antibody is positive is something called the hepatitis C RNA test. And that tells us whether you actually have the virus and need treatment. So we want to try to get everyone that has a positive antibody test to get that follow-up testing if they haven't done so in the last year. And then finally, we have a goal of 100% of people who test positive for hepatitis C RNA that have a detectable viral load, meaning they require treatment, that all of those patients will start treatment either with us or with another organization in the community. So some patients don't meet criteria for being treated in the primary care setting at CMU, and they need to see a specialist. So some examples of that would be people that have co-infection with hepatitis B or HIV, and we would help them get connected with a specialist in the community that would be able to treat them if we're unable to treat them in our clinic. And then so how we're accomplishing our goals is part of the quality improvement project that I'm working on as part of my doctoral work. So one of the things we're doing is that I'm personally contacting every patient who enters the methadone program to make sure that they're given an opportunity to undergo screening for hepatitis C if they choose to do so. I'm personally following up with every patient that has a positive hepatitis C antibody test to offer them follow-up testing. And I'm also working with patients who do have detectable viral loads to get them engaged in treatment, either with APT, with one of our providers, or helping them get referred to someone in the community so that they can be treated. One of the things we're also doing is promoting our hepatitis C services and forums like this. I've also been going to our methadone clinics at North Haven, West Haven, Legion, Long Wharf, and then also our residential program to share with our patients about services that are available to them through the APT Foundation.
Oh, thank you. Do you have a sense, Ben, of how many, like of the total universe of APT patients, how many are affected?
Yes, so we've done some preliminary data analysis on, I've been collecting a lot of information. So it varies from month to month with the patients that are coming in, but the data tends to show that between 1 in 3 and 1 in 2 patients in our organization have a positive hepatitis C antibody. Whether they have an infection that needs to be treated is still data that's in process. But we do have quite a number of patients in our organization that are affected who would like to be getting screened more often.
You mentioned that that sexual transmission is one of the pathways. Is it considered an STI in the sense that if you're positive, you go and tell your partners and recommend that they get, I mean, what's the latest guidance or thinking on that?
So I would say generally we do recommend that patients that have sexual contact who is hepatitis C positive, they're certainly able to be tested just to see if they have been exposed. But it is a rare, but it is a possible STI and we would test for that if patients chose to.
Mm-hmm. And the new drug, I mean, I remember when people with decades of recovery from substance use disorder were then finding out that they had hepatitis after many years in recovery. And then it was like a death sentence. It was like your liver's going to fail, get on an organ donation list, or, start saying your goodbyes. And now there's this drug that can literally clear the body of the virus. You just have to qualify for it, get hold of it somehow. So, I mean, that's like pretty revolutionary difference in people's life experience and prognosis to this thing. Like in our lifetimes, that's been a big change, right?
It's been a huge transition. And I think a lot of patients are shocked to hear that treatment's available to them, even if they've been treated before, like they got interferon and it may or may not have worked, which we've had with some patients. Or they were treated with one of the novel drugs and got reinfected. So there is treatment available, and we're here to help people get connected to that treatment. But it is a life-saving therapy.
Do you think part of the reason that the news hasn't gotten out so widespread about treatment is that once somebody's cured of it, there's still stigma and they don't even want to, address the fact that they ever had it? So then you wouldn't know, right?
There is a lot of stigma about hepatitis C. people are worried about the perception from others. They don't want to even admit to themselves sometimes that they have it. It's just, I have this disease. It's not causing any problems. I don't want to think about it. And sometimes it's patients are just unaware of what it's doing to their body, even though they feel okay. So we try to put that in context for people that it is very treatable. It's very manageable. You can be cured. But it is very hard for people sometimes to enter treatment for that reason. It's they worry about the perception of others.
Well, Dr. Shi, I want to call you in at this point to talk about like how the APT Foundation addresses the stigma aspect in particular, and just how that fits into your whole model of the way you work. Is that a clear enough question?
I think having central medical unit at the APT Foundation, again, it seems like a very simple idea, having a medical facility affiliate with the methadone program. It is still a relatively novel idea. So most methadone program around in the country do not have a medical clinic associated with their methadone program. And especially for us, we have a very expensive methadone clinic. So this really makes, and having an opt-out option really encourage patients to hear us out, so that that they would get tested and get treatment subsequently. And Eleanor, you had mentioned about patients who had been with the program for a long time. We have, again, on methadone program, over 4,000 patients on methadone and MOUD. Medications for opiate use disorder. We have old timers, I would call them, that had been on the methadone program for 20, 30, 40 years, who actually had hepatitis C and now is really coming to realize that they would need to get treatment. So again, with Ben's having this month being the hepatitis C month, we're really encouraging not just new admissions and new patients coming on the treatment to get tested. We really encourage all patients to get tested for the hepatitis C and to know their status. Oftentimes, patient would realize that, oh, I think I had Hep C before, and they actually be pleasantly surprised that, oh, I don't have any detectable viral load. We do have patients that had passed away because of hepatitis C with the hepatocellular carcinoma. We also had patients that actually got liver transplant because of got treated early for their liver cancer. So I think all those are really good ways for us to incorporate our medical care for patients. Our patients are getting older. The longer they have with Hep C, the more likely that they might have complications of that. In addition to just checking Hep C on patients with drug use, I think it is really a health maintenance issue in general for anybody, I think over 50 or 50 years old, to have at least one test of hepatitis C, just to find out, because oftentimes patient doesn't even know they have it. And although if they're not using drugs, their risk of transmission is relatively low, but there are definitely things that we tell patients that, don't share your toothbrush. Sounds like a silly thing, but again, if there's a lot of bleeding or gum diseases, they might, in quotes, be passing to others, which is again low risk, but we should just educate patients about that too. So again, I think for our community, I'm glad that, we are able to work at this clinic and give patients the needed education to how to keep them staying healthy.
Really good information. A question that came in: how often is testing recommended? Quarterly, monthly, yearly? Is reinfection a concern?
So the current guidelines would be that all adults should be offered testing at least once in their lifetime. But for people that have risk factors, so ongoing substance use, they should test at least once a year. And that's something that we would help facilitate. Reinfection is a concern. We do have several patients that are in the process of getting treatment now who were successfully treated and subsequently reinfected. So even if you've been successfully treated or you've been told that you cleared the virus on your own, it's important that you continue to test regularly, especially if you still have risk factors.
And when symptoms do become present, can you go over again what the most common symptoms are?
So I would say that most patients, they're very subtle symptoms and they're often dismissed as something else, like, oh, I just didn't get enough sleep last night. People feel tired, they have achy joints, things like that. They're very mild. Some patients will have symptoms in the acute phase, so shortly after they've been infected. And those are more traditional hepatitis, general hepatitis symptoms. So yellow skin, eyes, pale stool, nausea, vomiting, upset stomach. But that's a very, very small number of patients. The vast majority of patients won't have any symptoms at all, or if they do, they'll have the more mild symptoms that are a little more chronic in nature. So mostly fatigue and joint pain.
Just the inflammation, just feeling unwell.
Right.
Mm. Thank you. So you mentioned tattoos and needle sharing. You mentioned tattoos and the needle use in tattoos as being a way to contract the disease. And people who love tattoos as a form of expression joke that they're like, potato chips, you can't just have just one. And people, get multiple tattoos and, really incorporate it as a lifestyle. Would that in itself be a reason to get tested more often?
So it would really be more about getting them it depends on the setting. So if you're getting your tattoos or piercings in a licensed tattoo parlor that's following recommended sterilization practices, so autoclaving needles and equipment and things like that, then that's less of a concern. But in people that are getting tattoos in environments such as when they're incarcerated or from a friend outside of a business setting, those are much higher risk activities, and we would recommend getting tested even if they've been tested before. Personal items as well, so like barbering equipment, we've had some patients that were believe that they were exposed from that. So like even nail clippers, toothbrushes, sharing personal items with someone that has hepatitis C is a way of becoming infected as well.
Well, I'm sure the owners of licensed, well-run tattoo establishments would be pleased to hear your response and know that they're not. I think the reason tattooing was actually illegal into the 1990s in Connecticut was because of, ideas about very close links with hepatitis. But so we know now how to prevent it. And these well-run establishments do just that and follow those health rules under licensing. Thank you. Dr. Shi, from an epidemiology standpoint, how many people do you have to treat to make an impact in community spread?
Well, again, Ben had mentioned that, if we treat one person for hepatitis C, we might be able to prevent 20 additional cases of spreading. So I think the impact is high. And the other part, actually, I want to make sure that we mention that for patients, when we just do the initial screening test, we also recommend patients who had history of using injection drugs for actually vaccination. So this is also a really good opportunity for us to recommend patients, apart from telling them about if they wanted to inject drugs, techniques to make sure that their, the injection equipment is cleaned and such. Also provide them education about vaccination, including, again, hepatitis A and hepatitis B, not to mention about being evaluated for HIV. So those are the more important, additional important part about the screening and having a frank discussion about what hepatitis C means. And again, it just comes as a whole package of the initial screening tests that we do, and also about education, obviously about the medication. I think for us, hopefully at CMU, we have probably treated over 500 patients or more with hepatitis C successfully. So the treatment itself, again, from the data, that's really nothing any new anymore. And absolutely, the medication itself is very, very expensive from pharmaceutical company. And I generally tell patients in particular that this is really, in the state of Connecticut, we are so fortunate that providers do not have to jump through hoops to get authorizations. Patient doesn't have to wait to be super sick to be on these, life-changing medications. So, so I think for us, we are really fortunate epidemiologically. For us in Connecticut, the more we treat, hopefully we can, again, really suppress the transmission of Hep C. Other states is a completely different, program, and other states are really just catching up to what Connecticut is able to perform. In the southern state, Hep C treatment, it's still relatively a novel idea.
So one more way that Connecticut is leading in public health and disease management.
Absolutely. And I think that we have collaboration with, the hospitals. And if patients get found out that they have, higher level of cirrhosis, they're also absolutely important to get the Hep C treated and then take care of the other liver disease. Again, it's prolonging patients, life with the best setting, so that they can live in healthy and supported and drug-free life.
Well, we are coming to the end. So if anybody does have any last questions, make sure you get them in. Do you think having the screening services at APT allows you to get more people screened than if you had to send them somewhere else?
Absolutely. So one of the research has shown that care fragmentation is a huge problem for patients that are living with hepatitis C, and also for patients that are living with substance use disorders. So having everything under one roof increases or has been shown to increase patient success rates in being treated for hepatitis C. So an APT is a perfect example of that, offering primary care services, addiction medicine services, addiction psychiatry, all under one roof with hepatitis C treatment embedded all within it. It's a one-stop shop for patients. They don't have to go to multiple providers to get all these services offered. They can come to one location and have really comprehensive care in one place.
And for the medications that you went over that are available to treat hepatitis C, have there been any known interactions? Or are they compatible with treatment for opioid use disorder and the common ones that that foundation gives?
So they are definitely compatible with treatment for opioid use disorder. That in and of itself is not a contraindication. Where it can become a concern is with interactions, in particular with medications that have a protease inhibitor in them, such as Vosevi and Mavorit. And that also is not a contraindication, but it just requires the clinician to spend some time reviewing medications with the patient, seeing what they're taking, and deciding together with the patient which option is the safest for them that will have the fewest side effects.
Great. Well, anything coming up on the horizon research-wise or at the APT Foundation for projects that you want to drop on us as we wrap up?
So we're launching kind of a part 2 of the preliminary work that we did. We did to get the data that we recently submitted to a conference. We did a 3-month retrospective review of patient data, and starting this month, we're going to be adding some additional interventions to try to increase our screening and treatment initiation rates at APT through the fall. So we have, over the next few months, we'll be seeing more and more activities at APT to try to get the word out to our patients, to encourage them to screen and get treated.
And what kind of partnership or action from, say, a local health department or something like that would be helpful? Any thoughts on community partnerships for tackling hepatitis C?
So I think, as Dr. Shi mentioned, we're very lucky to have the ease of accessing therapy that we do. It's not the case in other states. It's very difficult to get some patients started on treatment. One of the challenges that we have is doing something called reflex testing. So in a perfect world, when patients come in and get their hepatitis C antibody test, it would automatically then go through additional testing called hepatitis to check for their viral load. Currently, because of cost constraints, we have to have patients come back for a second blood draw. And that would require the organization to absorb the cost of that additional testing, which is very expensive. So if there's a way to find ways to get additional funding where that would be a possibility, that would be great. Because it also gives us more useful information as to how many patients are actually infected, actively infected with the virus and need treatment versus those patients that were exposed or managed to clear the virus on their own.
Well, great. I want to thank you both so much for just really valuable survey of this topic and more appreciation for the role that the APT Foundation plays in combating it. These community forums cover an array of topics. The last one was on the intersections between chronic pain and substance use disorders, and the recordings from that, as well as some DIY, some self-directed overdose prevention training in another community forum, are available on the APT Foundation's YouTube channel. This recording will be available in about a month on that channel as well. If anyone has ideas for topics or someone that they've heard speak in the community that relates to APT Foundation's services, we are certainly open to suggestions, and you could get in touch with the APT Foundation through the contact form on the website and make that suggestion at any time. So we wish you well, Ben, in your continued studies and research and everything that you're doing. And I don't know if happy rest of Hepatitis Awareness Month is a greeting, but certainly best wishes for sure. And Dr. Shi as well. Thanks, everyone.
Thank you so much. Yep.